Thank you, Dr. Ariel, for having me and for inviting me to give the talk. It's a pleasure, and I can see the poster at the back of your office. It has that work we done back in Manchester on the nerve check. Right. So the title of my talk is Clinical Practice, Quantitative Sensory Testing, which we covered a lot about it today, and it's diagnosis of neuropathy. How can I close this because it's blocking my screen? 1 second. Okay, perfect. So quantitative sensory testing has been included in several consensus for sensory and painful neuropathy, particularly diabetic neuropathy. It assesses for vibration, warm and cold perception threshold, allodynia and hyperalgesia to mechanical and thermal stimuli. Warm and cold perception threshold and heat-induced pain, they assess for small fiber sensory neuropathy, which are not detectable by nerve conduction studies. And mechanical and vibration perception threshold assess for large fiber sensory neuropathy. Now, it has a moderate correlation with nerve conduction studies because they assess different nerve fiber assessments, and therefore these two assessments, nerve conduction studies and the QST, they are complementary. I should say abnormal warm perception threshold and cold perception threshold, although they present, they present in both painful and painless neuropathy. It means that warm perception and cold perception testing are necessary for painful neuropathy assessment, but they are not sufficient for the development of pain. And mechanical and vibration perception threshold studies have shown that it can predict diabetic foot ulceration. High vibration perception threshold is associated with 5-fold increase in medical costs for diabetic foot ulceration and amputation. The way it works, we apply the thermode on the foot or the hand, specifically in the area where there is the pain or a sensory deficit, and the patient needs to respond quickly to the stimuli. And therefore, this is a test that is subjective because it depends on the patient's motivation, attention, and cognitive function. And it's not recommended as a standalone diagnostic test due to these variable study results and testing methods. There are several devices available for the test quantitative sensory. One of them is neurotissimometer, but it only has one modality, the vibration perception threshold. The other one is the TSA neurosensory analyzer, which comes with a laptop and it's a quite big device, similar with the Case 4. Now, the nerve check, though, that's an interesting thing, which is more useful for clinical practice because it's a small device and portable, and it assesses 4 different modalities. It assesses for vibration, cold and warm perception threshold, and heat-induced pain. The way it works, it applies the method of levels for a series of predefined vibration stimuli and the methods of limits for warm and cold stimuli. It has, for example, here for the vibration test, 9 different stimuli and includes null, and 5 different stimuli for the cold or warm perception threshold, and only 1 stimulus for the heat-induced pain. Its output is categorical in terms of degree of abnormality, and I had the chance back in Manchester to do a study to test the validity of the nerve check for sensory neuropathy, and we found that it has a good reproducibility. Its interclass agreement for vibration perception threshold was 0.79, for cold perception threshold 0.86, and for warm perception threshold 0.71. Finally, it has good diagnostic accuracy for sensory neuropathy. When we compare it against the neurotissimometer as a gold standard method, the area under the curve of the nerve check for vibration perception threshold was 86%. And when we use the TSA2 neurosensory analyzer as a gold standard method for warm and cold perception threshold, the area under the curve of the nerve check was 79% for cold and 72% for warm perception threshold. In a separate study where we wanted to see how the nerve check performs compared to assessments for large fiber assessments using the nerve conduction studies and for small fiber assessments using the corneal confocal microscopy and skin biopsy for epidermal nerve fiber density and the McGill for pain. And what we see here, what's interesting is that when we look at the vibration threshold test of the nerve check, it, as we would expect, it performed better against nerve conduction study, specifically for the sural nerve action potential and the sural nerve conduction velocity, compared to the other modalities like cold and warm perception, where the area in the curve was lower compared to the vibration against nerve conduction studies. But when we compare it against the small fiber assessments, like the corneal nerve fiber density, we see that the cold perception threshold and the warm perception threshold, they outperform the vibration perception threshold because they are assessing small fiber assessments. And yes, they can also detect pain with the vibration and with the vibration test and the warm perception threshold. Finally, we had another study done here in Manchester that Professor Malik briefly covered, where we had a collaboration with studies in different Arab countries, including Qatar, Saudi Arabia, and Kuwait, where we recruited patients with type 2 diabetes, aged between 18 and 85. And we performed vibration perception threshold using the neurothesiometer, where we defined impaired vibration perception threshold, anything equal or higher than 15 volts, and high risk for diabetic foot ulceration, anything equal or higher than 25 volts. We recorded neuropathic symptoms, including burning pain, painful cold, electric shocks, tingling pins and needles, and numbness, as is in the DN4 questionnaire. And the way we defined diabetic neuropathy was based on one or more neuropathic symptoms and impaired vibration perception threshold. Previously diagnosed diabetic neuropathy was self-reported, and we used the DN4 questionnaire to define painful diabetic neuropathy. And for diabetic foot ulceration, it was based on breaking the skin of the foot that involves the epidermis and or part of the dermis. Now, the prevalence of diabetic neuropathy was 33%, of which 54% were undiagnosed, and 52% were at high risk of diabetic foot ulceration. And the prevalence of painful diabetic neuropathy was 43%, of which, again, it was alarmingly high, those with undiagnosed, which was 54%. When we focus on the risk factors of diabetic neuropathy, the prevalence of diabetic neuropathy was higher in those with age, with duration diabetes, with full glycemic control, hyperlipidemia, obesity, and smoking cigarettes, but it was lower in females and those who were performing physical activity. This is after we adjusted for confounding factors, at which point hypertension lost its significant association. When we look at the risk factors for painful diabetic neuropathy, it's the opposite with the female because it's higher in females, and the duration diabetes, it's higher with duration diabetes, with poor glycemic control, hyperlipidemia, and obesity. And again, it was lower in physical activity. Age lost a significant association with painful diabetic neuropathy after we adjusted for all the confounding factors. And final note about the prevalence of diabetic foot ulceration was higher with diabetic neuropathy, with hypertension, and with vitamin D deficiency. That's it. Thank you very much.